All right, well, we're ready to get started, and, can y'all hear me? Okay, so we're good. They can hear me. I want to welcome everybody here today. Thank you for coming, for getting out in the cold weather and showing up. You're in for a treat. I want to just tell you a little bit about myself. I am Tony Lawrence. I am alumni from Lubbock Christian University, and I currently am employed with Texas Tech in the School of Nursing in the traditional undergraduate program. I teach anywhere from 120 students to 150, so it just depends on the course. Today, we are going to be video recording, and so we want to thank Justin for recording for us. And the restrooms, I'm going to just cover some things that I think are important. There's refreshments right over there. Help yourself. Get up anytime that you need to. The restrooms are right outside the door and around the corner. Good? Okay. We will close promptly at 5:30 and let you get on your way. Toward the end of Dalton's presentation, there'll be a little bit of time for comments, questions, or anything that you'd like to clarify. Good? All right. Well, let me introduce James Dalton Keel. He has 13 years of nursing experience, 9 years of critical care and emergency room nursing, 2 years as an RN circulator, 2 years currently as the Pan West Regional Nurse Consultant for HIV services. He oversees case management and clinical services for 63 West Texas counties, operating in 4 hubs, and those include Amarillo, Odessa, Lubbock, and El Paso. He is also adjunct faculty here at Lubbock Christian University, and he's also a captain of the U.S. Air Force Reserves. He received his BSN in 2005 and his master's in 2010 here from Lubbock Christian University. He has several projects that he's currently working on. All of them involve HIV. Some of them have to do with the adolescents, those in childhood, and then some are in epidemiology. They're co-infections, and also he is working with the impact of the implementation of the Affordable Care Act and how it's affecting HIV national strategies. We also have Dr. Stephen Bonner, who is Associate Professor here in the Bible Department at Lubbock Christian University. His position is the Director of Youth and Family Ministry. He is an expert in the adolescent development area, and he teaches several courses in the graduate and undergraduate Bible department. So thank you for being here also. We also have Ricky Lee Vaughn is here. Thank you for coming. Ricky is currently the lead medical case manager for SPCAA Project CHAMPS, the Ryan White provider in Lubbock, Texas. He has been working in some capacity in the field of HIV and STD for over 11 years. For the last 2.5 years, he has been working as part of the AIDS Service Organization, as well as serving as member of the HIV Multidisciplinary Treatment Team through Project CHAMPS. He is contracted through the medical clinic at the Texas Tech University Health Sciences Center Department of Internal Medicine. And then on the telephone, we have Dr. Alozi, and he specializes in infectious diseases, HIV, and HCV. He's the Chief Medical Informatics Officer at Texas Tech University Health Sciences Center in El Paso. He is also an assistant professor at Texas Tech University Health Sciences Center, and also works as infectious disease consultant at University Medical Center in El Paso. So those are everyone that we have here today, and I want to turn it over now to Dalton and Keel. Thank you.
Well, okay, I'm glad everybody could come see a lot of my students from research last semester. It's good. Glad y'all came to hear me again, over again, yes. So let's just make sure that we can hear Dr. Lozzi real quick. Dr. Lozzi, are you there? Okay, we're having a little trouble hearing you. Hang on just a second. I'm going to see if we can fix that.
Can you hear us?
Yes, he can hear us.
Well, it's supposed to go through there. I'm not sure why it's not, but we may have to repeat.
It was coming through the speaker. Mine was just turned off. I heard him respond.
You did? Let's try that.
Okay, let's try it one more time.
It's not coming through that very well, is it?
Yeah.
We may have to repeat.
We're having a little trouble hearing you, but I may just repeat some of your comments then. Okay, great. Okay, I'll go ahead and get started. I've got quite a few slides to get through here, and a lot of them have to do with epidemiology. This was a little presentation that I had up here just to kind of show some of the guys that I had talked about, presentations and some of the new technology that's going to soon replace PowerPoint, I think. Anyway, let me pull this up here and get this going. All right. So got. There we go. All right. So, okay. What I'm going to do real quick is I'm going to talk a little bit about the epidemiology overview of HIV and just kind of bring you back up to speed. Some of you have been here before, some of you have not, so just to kind of give you a quick recap. Then I'm going to talk about Texas HIV statistics. I'll talk about Lubbock and the surrounding counties. The National Strategy for HIV, some Patient Protection and Affordable Care Act, things that have affected the ACA's effect on Ron White grant and HIV funding. And then Texas Strategic Focus, Adverse Childhood Events, which is some research that I'm doing, and then takeaways and future outlooks. Okay, just real quick, we'll go through the epidemiology here. And essentially what happens here is this is just a breakdown of males and females, roughly 900,000 at the end of 2010. You see here there was the breakdown of ethnicity. You can see females, big disproportion there. And then here you can see the disparity a little better with African Americans. And this is something that's been identified, it's widely known, it's something that's being pursued as one of the agenda items for the Texas Strategic Plan and the National Strategy. You can see some of these other breakdowns here, but not nearly as close to the disparaging numbers for African American males, especially men who have sex with men. That's one of the main identifications there. Then the rate of adults and adolescents living with a diagnosis of HIV infection by the end of 2010, okay? And so here you see Texas. It's kind of hard to see maybe, but 318.6, that's per 100,000 is kind of the rate that of adults and adolescents that were being diagnosed. And so here's that number again, it's close to 900,000. Then you see here the rates which have been included now for age 13 and under. And that was something that I was into about 2 years ago, really heavily saying, hey, we need to, this is something we need to do. Hey, waving my hands and red flag. But you see there's the number here is really just proportionate to what states were really reporting. And some of the states had incomplete data. There's a whole lot of statistical things that go into this. And typically it's always behind several years, and it's usually reported every 2 years because it takes so much time to accumulate that data at a national level and then put it together and then get it out to present. So anyway, it runs at a rate of about 4.6 to per 100,000. Then here's another breakdown of transmission category. So male-to-male sexual contact you see is the highest. Injection drug use is actually lower than what a lot of people anticipate. A lot of people think, yeah, you know, you get HIV from drugs, using drugs and whatnot, but that's not necessarily the case. Although IV drug use is a factor, it's much lower than what you would think with than actual male-to-male sexual contact. STD epidemiology in Texas. We'll just move right along and talk about some of the STDs that are prevalent here. There's roughly 120,000 cases in 2012 for Texas as a whole, and this is a representation of the area here. And you can see there's Lubbock, Amarillo, El Paso. We've got you know, Dallas area, Houston, whatnot. So Lubbock's pretty high. You see, the darker areas there about 499 to 1,288 cases per 100,000. Then here you see a breakdown of by year, 2001 through 2012, males, all ages, and then particular attention I wanted to pay to 15 to 24, that being the highest class here, 15 to 24-year-olds, and actually even younger than that, 2012. You see that there? Okay. Then black, Hispanic, and white, breakdown of ethnicity. You see that disparaging number there again. It's much higher among women in the black community than Hispanic and white. There's all sorts of factors that go into that. I mean, I'm sure that's a question that'll come up at the end. It often is. It talks about you know, some of the stigma and different things that are associated with going to get treatment and things of that nature. So a lot of that plays into it, and we can talk about that towards the end. But in 2012, the gonorrhea cases here, roughly 30,000, just over. And another little preview here for gonorrhea. There's, you know, Texas, Lubbock, Amarillo, El Paso is actually lower than us, 150 or more. And we're up there with kind of some of the bigger metropolitan areas. So then gonorrhea, again by ethnicity, black again, has a disparaging number against Hispanic and white. And then we go into primary and secondary syphilis. You see here in 2012, we all but thought we had gotten rid of it, you know, along the 2000 era here. And then, man, it just resurged and is back with full force now. So something that we're really having to keep an eye on. Again, that same breakdown. And there's Lubbock. It's one of the higher numbers. The breakdown for ethnicity. And here's the male-to-male sexual contact being prevalent in that arena as well. Then you have female at the top here being lesser, and then other male, primary and secondary syphilis. Okay. This is the HIV annual report. You see here, people living with HIV gone way up, deaths gone way down. We have much better medicine now as of around this time frame here, 96, 97. That's really extended the lifespan. And also with this, you see probably every year, roughly around 4,000 to 5,000 cases are being diagnosed in Texas, and that has now translated into 73,000 or so individuals living with HIV in Texas. These are new diagnoses. Of course, they'll jump all around and vary from year to year. And then deaths among cases, like I say, is way down because of much better treatment. This is just a different bar graph that shows you the cases versus the rates, and the cases are in red here. And basically, I explained this in the previous slide. Here you see HIV cases rates by race and year, and then again you see this really big disparaging number here for the black African American community versus all others. New cases by mode of transmission. Here you see again males who have sex with males. And let me just take a brief minute to explain that. Males who have sex with males also have sex with women. And that doesn't mean that they're gay or bisexual or anything of that nature. They could be married and having sex with males. They could not identify as gay, have come out of the justice system, had sex with men in there, and or were raped or whatever. and then have sex with women. So, I mean, there's any way to categorize that, okay? There's not just any one way to define or categorize that. It's really broad, actually. Then IV drug use, men who have sex with men, and IV drug use, and then heterosexual. Then this is just a different way, like a candlestick version of that, based on Austin, Dallas, Fort Worth, Houston, San Antonio, East Texas, and U.S.-Mexico border, and TDCJ, which I'm glad they're including that now because that's been something that's eluded us for some time. Okay, so then newly diagnosed cases by age at diagnosis. Again, this is where I'm really emphasizing, and I'll show you later on about how we can take some steps to try and prevent this. Of course, these are your college years. There's a whole lot going on. You know, any number of things can contribute to that. You're away from home, whatnot. Dr. Barner will probably speak to the fact of adolescence kind of stretching out there a little bit, you know, more people staying home later and things of that nature. You know, he may speak to that. Huge difference between these two, but there are some preventative measures that we can take to get in there and try and avert that. This is just by age again, and we're looking at this number here being represented on the last slide in a bar graph, but it's just here in a line graph. And that's the concern. So actual diagnosis of AIDS, gone down overall in 2012, but the number of cases of ever being diagnosed with AIDS has gone up. And typically there's 3 stages. There's the early stage, which is really virulent. It's replicating in your body. And then there's a secondary stage where you may or may not show symptoms. A lot of people say that when they first get HIV or diagnosed with AIDS, that it's like the worst flu they've ever had. And then moves on into the 3rd stage, which is actually where your CD4 count, your cells that turn on your immune system get eaten and get destroyed. And so in that regard, your immune system can't be activated. So, this is actual AIDS diagnosis where they come into treatment at that point. Okay. And then this is AIDS cases by race. Again, that disparaging number versus all others. And here's the numbers for right up till now. The rates by age at diagnosis. And you see this one's on the rise as well. These have pretty much stayed the same. And then this one's creeping up. That's just a graph of that. So people actually living with AIDS, this is the most recent numbers, 456 cases per 100,000, 921 cases per 100,000 for a black African American, and then male also being a high category. And then there's a breakdown by age group. Okay, so rates of people living with HIV or AIDS by gender. Again, males more than females. This is another opportunity for the ladies to say, hey, it's our fault. So just put that out there. So again, by race and ethnicity, a little breakdown here. And people living with HIV and AIDS transmission categories. And you see intravenous drug use actually not as high as one would think. Pediatric transmission rates, about 1% of that. Heterosexual contact, men who have sex with men, and IV drug use. And then men who have sex with men having the largest portion of that. Females and males break down between the same category. And then the trend over a longitudinal aspect. Okay, so in this region, what we have here is region 1. That's us in Amarillo. That's in the smokestack of Texas, the top part that sits on the panhandle, under the panhandle of Oklahoma. Then 9 and 10 is El Paso and Midland, Odessa. And this is HIV infection cases, the rate per 100,000. And then this is the actual cumulative diagnosis for the end of 2012 right there. And then all that could have been weeded out by, maybe it's a false positive. There were many other things, many other aspects that could have weighed into that number. And then the actual number of people living with HIV was 72,900, which is roughly 73,000. And then AIDS, 2,541. This is the 25 counties with the highest case counts. Lubbock has actually moved down to 20 from up in here. And you see Harris being Houston, Dallas, Bear, San Antonio, and then Tarrant, Fort Worth, and Travis there. Pretty much across the board. Lubbock is moved up here at 44 in 2012, 9 in 2011. And then people living with HIV, and that's I think we're off the chart there, so that's a good thing. We're down at the bottom. So 25 counties with the highest case rate, again, continue with HIV infections. You see Dallas has now surpassed Houston, and for actual new infections. So that's the big deal now, because way more people in Houston, but they're actually have better control of their community viral load. Okay, so Dallas is going to far surpass them in the years to come. That was something I was saying a couple years ago, because they were just really on an upward trend. Lubbock's actually gone down in the line here, gone way up there based on the difference between 2011 and 2012, and really unusual. This is Post. That's the Post area, the Garza County, and I thought maybe that was a typo. Maybe they meant Gregg County, but then I see Gregg gone down the line there, and maybe it's just because of the region and per capita. There's a high number of cases versus per 100,000 of people in that county. So I don't know. That was kind of a shock to me. So going right into the National HIV/AIDS Strategy, the goal of it, President Obama got some really top-notch experts to come in and sit down and try to write a plan, a strategy to say, hey, how can we combat this? We need to make this go away. We need to get a handle on this. So the main goal of it is to reduce the HIV incidence. Okay, so that is going to be done by increasing access to care and optimizing health outcomes, reducing HIV-related health disparities, and then achieving more coordinated national response to the HIV epidemic. That means we all have to work together, okay? Everyone. Because HIV looks like you, it looks like me. It doesn't discriminate by socioeconomic class. It doesn't discriminate by color, race, ethnicity, any of that stuff. I mean, it affects everyone. And probably if I asked or polled in here, I mean, somebody in here knows someone that has HIV. Okay, so what that looks like. So in the spectrum of care, nationally, we're looking at this number here, 1.2 million HIV infected. You got HIV diagnosis of about 941,000. You've got linked to care here, roughly 725,000, and 480 are actually retained in care. So that's, you're talking about maybe half of this number of diagnosed. And then the people who actually go on therapy, it's about 426,000 of that original number. And then 328,475 are suppressed and actually have non-detectable or less than 200 copies per mil in their blood. So that's where we want everyone. And we'd actually like all these bars to be straight across. That would be the goal. All these would be straight across matching. But unfortunately, you see that there's a big difference from this, living with it, being diagnosed with it, and then actually getting care or staying in care. So if I was going to create a model and say, hey, scientifically, or in respect to research or whatever, I would say, okay, this is, we're going to have to gather everyone or get together here, and we're going to have to engage people, and then we're going to have to link them, and then we're going to have to retain them, and then we're going to have to make sure that they're suppressed or stay on therapy or stay in therapy. And so that model would just flow across like an arrow, like that with boxes, for those of you in my research class. And then this is what it looks like if you put a shape to it. So for every 100 people with HIV, 80 are aware of their infection, 62 are linked to care, 41 stay in care, 36 get therapy, and then 28 have a low virus count in their body or undetectable. so not much. Okay, so then along comes the Affordable Care Act, right? Well, so if you read the national strategy, if you just read the executive summary of the national strategy, it talks about the Affordable Care Act. It says, yeah, you know, with the implementation of the Affordable Care Act, all these good things are going to happen, blah, 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 all this stuff, you know. And we're going to put it together and make it, you know, shake it all together, and then out comes good things. Well, the purpose is to expand access to health coverage for health care coverage for millions of Americans regardless of status, period. Not HIV or anything else included, but just period. You know, everyone across the board is okay. So everyone likes that if you're 26, you can stay on your parents' insurance. You know, everyone likes that there's no pre-existing condition. All those things, they sound great, okay? But I liken that into a mousetrap. You know, they're giving you the cheese, and then, whap, here comes this big old bar, okay? And I'll show you in a minute. So then it promotes interdisciplinary care coordination from the adoption of electronic health care records. And any of you guys who work in the hospital know about that right now. I mean, that's a big thing. Everyone's changing over to EMRs or whatever your system's called. And it's supposed to, you know, really help focus on patient-centered health care, family-centered health care, all these outcomes and, you know, your CAPS and all these other statistical methods that they're going to use to say, wow, you guys are really doing a great job in caring for individuals. So then there's going to be critical efforts to address social determinants and establish essential health core benefits with Medicaid or private health care beneficiaries. And what that is a CBO, okay, a community-based organization. So StarCare is one of them. And there's several others. And what they do is, it's, you know, it used to be at Lubbock MHMR, and they have several different programs that they oversee. I know ComBest has several programs, lots of grants that they receive to actually, you know, establish a group of care, of different modalities of care. So like if you have primary care, you need primary care besides HIV care, there's a primary care physician that you can see, or they link you to one, or if you need nutritional supplements, or if you need a dietitian, or if you need other benefits, they can link you to those things, those resources within your community, okay? And then improve the key population data collection and quality improvement, because everyone's worried about quality. Quality of care, quality, big, I mean, there's jobs posted all the time about quality this person or quality that. So, and there's people that are going around actually just looking at the quality of your data in your EMRs. So then it's also created the Joint Select Committee on, I'm sorry, let me go back just a minute. So at the same time that ACA was happening, there was this Fiscal Budget Control Act, this fiscal cliff they called it, the Budget Control Act of 2011. So I'm gonna dip into politics a little bit here, and if I had to use an analogy, what I'd say is like I'm jumping into a pool trying to get a diamond ring, which is the actual ACA benefits, but there's a whole lot of leaves and dirt and debris on the top. So either way, I'm gonna come up and be dirty, right? Whether I go in or I come out, I'm gonna be dirty. All right. So what's happening is in the politics side of things, it created the Joint Selection Committee for Deficit Reduction, right? So they recommend all these deficit reductions, all these cuts and all this stuff like that. Okay, well, the problem is they failed. They just disbanded, broke up, nothing worked. So then sequestration came in, right? Everybody heard of sequestration? Okay. So what that means is it's just the enforcement mechanism. Boom, it just chops. Like if you've got your arm out there, it just chops it off. That's it. And you're left with whatever else you've got, okay? So the cuts are spread evenly over 9 years, but I'll show you in a second here. So January 2013, I'll probably just put this in here to gripe about it, but non-defense discretionary spending and 9 to 10% cut in defense. So that means me and Gary couldn't go on annual tour. We had to stay at home and do stuff on the computer rather than go try our luck out in the field or whatever. So probably just put that in there to gripe. But anyway, so the impact then was core prevention measures, cut, 28 million. Expanded testing, cut, 5.4 million. HIV surveillance health departments, cut, 9.7 million. Anybody know where our health department is? Anybody know the address? Is there still one? Okay, yeah. So AIDS drug assistance programs, man, that's a big deal because everyone needs meds if you have HIV, right? 77 million cut, right? So like 15,000 people immediately were like lost access. Ron White Part B, cut 3 million. All right, so then viral hepatitis prevention, they were cut by 1.6 million, so that's about 9 workers that couldn't perform their duties for prevention coordinator and care. So then what this means is the ACA is going into effect. You got benchmark coverage for persons, up to 138% of the state poverty level, federal poverty level, for ones that expanded Medicaid. Well, guess what? Texas didn't expand, right? Okay, so then you've got HIV testing expansion, and there's for vaccines and all these things that high-risk people that have immune-compromised systems, they need vaccines, and other multidisciplinary services, primary care, nutrition, all these things like that. So then Medicaid's restricted for sharing costs for preventive services. So basically they can't share the costs; they've got to pay out. That's the bottom line. There's no you pay this, I pay that. No, they're responsible for it. Then all programs include the medication that's needed, the antiretroviral therapy for HIV. And then more work is needed on the preferred treatments, and then the PrEP, which is actually giving you preventative prophylaxis. If you have let's say I'm a guy who has sex with a guy, and I have HIV and that guy doesn't. They give him PrEP therapy. So they give him preventative antiretroviral therapy to let him not so that he will not get HIV, or his risk will be very low. And I'm supposed to be on antiretroviral therapy as well, okay? Because the problem is that if one person's on it and the other person's not, then the old virus is really smart. It gets in there and it says, hey, I can replicate in this guy, and I can change, and I can make myself immune to the therapy that's being given to this guy. So then I can change myself completely. Then when I can infect this guy, and his medicine won't even work. See, that's how smart HIV is. All right? So then Ron White programs can provide financial assistance for insurance. Pump the brakes. What? They cut us out. Okay. All right, so now we're up to this point here. Ron White programs, post-ACA implementation. Now we kind of know what's going on. We're up to the moment now. So the systems are not fully in place and functioning where they need to be, and they probably weren't going to have the kinks worked out for some time. We're not really going to know what the effects are for several years from now. Not all the services are covered despite what current coverages you have, and a lot of people know that because you may have got a letter in the mail that said, your coverage has been canceled. Wait a minute, President Obama just told me I could keep my coverage, right? Okay, and so, that whole big spiel went down. So then gaps won't immediately be noticed right away. I mean, it'll be something that we have to look at and over time find that, well, there was a really big gap in this coverage. What did we do to fix that, or how are we going to fix that? How are we going to address that? And likely that's going to cost a lot of money. And then focus needs to shift on providing some maintenance and care, the treatment adherence for individuals and their partners, like we were talking about, and community social resources, okay? And, Project Champs is here, my team's here, and that's kind of why we're all here, because this is everybody's problem, and we're going to have to talk about it one way or the other. So now, this is something that's just recently come out, and is in the Washington Examiner. And the way that this works is they took Obamacare and the premiums that for these income groups here, 53,000, 32,000, 30-year-old smoker, and then a 60-year-old non-smoker, two 60-year-old non-smokers making $25,000 a year. And so what that amounts to is that if you worked at Walmart and you were a family of four making $53,000 working at Walmart, which probably wouldn't happen, and your premium is going to be $962 on the exchange. You get a subsidy, which gives you $317 as your monthly payment. That's what you pay for your insurance per month. Okay, but if you worked at Walmart, you'd only pay $160. Okay, if you're a 30-year-old smoker, $428 with a subsidy, you get $352 as your monthly payment, or you could work at Walmart and pay $70. Two 60-year-old smokers, $1,365, $94 with subsidies, $134 working at Walmart. So there you go. When you turn 60, start smoking and get on the exchange, okay? No, that's not true. No, so anyway, that was just kind of an infogram to show you like kind of what I mean, now we know what the rates are. Now we know what kind of money we're spending, okay? And then Lee and Ricky have enrolled some people, and we know what kind of money that they're spending on their insurance premiums. By the way, they're navigators as well. Their program is really fantastic. They have a navigator grant, and they can help you sign up if you want. And I'm sure they have information and all that. But quick plug. But so the problem with that then is that we have a budget that they give us from HRSA, the state, and the state rolls it out to us, and then we have this budget. Okay, if you project those numbers out, I mean, man, we're going to run out of money in 8 months. If you sign up a whole bunch of people paying the same kind of rate, man, about 8 months or so, we'll be running out of money. We'll be asking the state for more money. Because remember, I went back a slide, cut some money out. Okay? So those are the real issues that we have to face with this. And that's boots on the ground, knowing what's out there right now, okay? And that was just kind of a fun thing that they threw out there or whatever, but I mean, we really know some numbers now, so we're kicking them around. So now we talk about the Texas 7, and this is the strategy for Texas. And so essentially it mirrors the national strategy in some ways. Increased proportion documented HIV, STD disease, so know your status, get tested, figure out if you have HIV or not, and get into treatment. It's cheaper to treat you if you're HIV positive and not in AIDS. Cheaper to treat you now than it is. It costs about $20,000 annually, but it's way cheaper than being on the ventilator, or getting pneumonia, or being in ICU or something of that nature. Improve the quality of community plans for HIV, STI prevention and services. So all of us coming together, working together. Whatever community resources whatever community resources you know, and we all get together and we share those. Improve or increase outcome monitoring. Really getting those numbers out there like I'm showing you guys in the beginning of this program. And then capacity building, so that this is a reality to you. By knowing the numbers, I mean, you can realize that this is really something that's big. I mean, it's something that's actually a problem. Capacity building, that's probably the biggest thing. Our community planner's right here. She's Maria Salazar, and that's her job. She does she goes to workshops. She gets people together and finds community resources. She helps with this huge resource needs assessment that we put out. And finds what people think they need, what's out there, how to link them up, and then now we've got this really big, nice program that's going to be on the website in a few weeks or so, or months maybe. And it's out right now. I got an email that has it in there, and I'll show it to you later. But anyway, it's all these community resources. It's a really nice thing with community resources. Okay, and all of that kind of helps with this capacity building. And like we can talk. Champs and I can talk, Combat Center, all these other places can get together and be like, hey, we have this program, or hey, we have this program, hey, we have this program, and sort of link up your services. Not just for HIV, but anything else, women's health, or any of those things. Improve systems to prevent appropriately managed perinatal transmission of HIV, STI, because that is a problem. I mean, if you're pregnant, we can actually get your baby to be born without HIV if you're HIV positive, because we can suppress your viral load. But you got to be in treatment. That's the problem. And then increase capacity of providers. It's like you can only stretch Dr. Alozi so far. You can only stretch Dr. Wynn so far. You can only stretch Dr. Desai so far. These guys can only do so much. I mean, we need to really work on nurse practitioners, PAs, people of that nature that can get put into service and really use to work with HIV. Individuals for primary care or whatever. And then I'll talk about this research that I was looking into, something that I talked about in previous research brown bags. Adverse childhood events, the ACE study. What this does is it's one of the biggest landmark studies. 17,000 plus people were in it. You see the breakdown of men and women. The outcome basically was that childhood exposure to any kind of adverse outcome creates a high potential for vast health and social problems. So what that means is if you're abused, and if you have psychological abuse, physical neglect, emotional neglect, substance abuse, mental illness, in your household even, separation, divorce, domestic violence, prisoner, prison, one of your parents is in prison. It affects you negatively. And it can really damage you as you're going through your adolescence or or your later childhood years, and cause you to take some risky behaviors. And those risky behaviors kind of look like this. You get exposed to this, you have this disrupted neurodevelopment, so you don't process things the way that a kid who doesn't have this does, and then you have social, emotional, cognitive impairment. So these are kids that they get bullied by social media or whatever else. We know of a kid here locally that killed themselves because of bullying on social media. That kind of thing. And with now, kids at this, 10 to 19 years old being the highest users of social media, being the highest users of electronic media, your smartphone and all of that stuff. That's something that we really have to watch out for. And then you have the adoption of these health risk behaviors. So, their parents drink, they get drunk, get hammered, wasted in the house, or, mom has various sex partners or something like that coming in and out of the house or whatever. So, the child drinks, to escape that reality, or child picks up some drugs or whatever, and they start, that's the gateway to it. And then you get up to the top of the pyramid here, and that's where you start to develop, disease, disability, social problems, and all those things that go into like law enforcement encounters, which also causes you to have negative outcomes. And then that leads to an early death. And I mean, sometimes you look at some of these statistics that they throw out there, and it's sometimes like 10, 15 years knocked off their life. Or they die early, in their adolescent years. They die in their 20s, that kind of thing. And this is the cascade here from conception to death. You guys can read that there. So what's the takeaways here? What are we going to do in the future? HIV is preventable. Know your status. Get tested. Tell everyone to get tested. Because as it stands right now, that was the initiative in 2010 going into 2011, and it's 45% of Texans have had a test at one point in their life. Just about 45%. So, Texas is big. At 1.1 million didn't even touch it, that live with HIV. So then HIV is everyone's problem, like I said, Everyone in here, it's your problem. Because it affects our community in some way. So no matter if it affects the black community or the Hispanic community or the white community, we all live alone. We all live in Texas. So we all have to work on this. And then the strategic plans and implementation phases are out there. They're in their implementation phases. And then now we're waiting to see what happens with these high-risk populations, how these numbers will be affected over the next 2 years or so when these numbers are reported again. And a huge disproportion of HIV in African American population, demonstrated that. We talked about less costly to treat if you get in with an HIV diagnosis versus a late diagnosis of AIDS. Identifying or the ACA having these gaps that are more costly than anticipated, and how we were going to look at that in the future. And then identifying these adverse childhood effects in the practice, and linking these people to resources that they need in order to decrease the potential for that youth risk behavior. And then incorporating evidence-based HIV, STI care into practice. And that really takes, there's a lot of guidelines out there, there are a lot of evidence-based factors. Taking that and putting it into practice and actually using it. Okay? And that's the conclusion for my part here. This is what we talked about. These are my references here. Any questions? Real quick, we're going to shift. Yeah.
I had a question for you, Dalton. I didn't see it in the breakdown in the young adolescent rates, but are you all looking closely at that correlation of increased rates among adolescent females who are victims of sex trafficking and the rapid rise in that social ill?
Yeah, that's a fantastic question, and the way I'll speak to that is if you see the way that the ACE model works with that particular identified population. It is something that is identified. Now, there's not, categorically what it would be is it would be listed probably as other in one of those realms or the other. And you would, I would have to go back and do deeper research. There were so many slides. I mean, I had to cut so many out because the epidemiology thing is about 80 slides long. And so there are things that address that specifically. And I know Medline puts out a lot of articles that speak to it specifically. And I was looking through right before we came over some of the risk behaviors and different things of that nature. So I wouldn't have clear numbers. I wouldn't have a clear answer for you, but that is part of the reason why I choose this as a research project, and then melding the two together to sort of stamp that out. Now, I will tell you, in the Air Force, we go through extensive training because the military notoriously, in evacuating large numbers of people, have moved trafficking individuals around. And we go through sex trafficking identification and training in the military as a flight nurse. Anybody else?
Can I add on the sex trafficking? If you're not familiar with the Human Rescue Coalition, is that the right name, Lee? Okay, Human Rescue Coalition. Are you familiar with that? Okay. I was going to say one of the issues that comes up with the sex trafficking is that sometimes those individuals, when they go into treatment, may, like Dalton said, be put into other categories as substance abuse, even though it was really a result of the sex trafficking. It may not be listed as sex trafficking necessarily. I think sometimes they get lost, and so those numbers aren't captured.
Yeah, I would agree with that. Maria Salazar, she's our community planner. I mean, there literally, like, I could take this and break it into 4 or 5 different, seminars. Really, we could sit up here and have several different occasions. And there's so much information here. I mean, I really had to rattle through it, and I apologize for just rushing through. But great wealth of knowledge. But there's a lot of things that connect that. The fabric is woven together pretty well there. Anybody else? Any other questions?
Any legislation on required screening of at-risk populations just across the lifespan?
Yeah, CDC in 2006 put out guidance that says, everyone from 13 to 65 should be given an HIV test. The opt-out rule in Texas is that really, literally, if you were going to go into the ER or go into your doctor's office, the physician would say, do you want an HIV test? And you'd be like, well, no, not really. Okay, well, blah, blah, blah. We'll see you next time. Well, then the opt-out way, the way that the opt-out works is that you come into the office and I say, as part of our routine screening for your health physical, we do an HIV test. If you have any questions, let me know. And it works like that. And the other thing is if you're doing all the things to get chlamydia, like you saw the one I did include that was women being predominantly the area there. If you're doing all the things to get those STIs, you're doing the things to get HIV, and so it's a missed opportunity at the doctor's office. It's a missed opportunity in the ER. Too often they're like shot in the rear and out the door, rather than really taking the time to screen. Because penicillin doesn't cure HIV. That's our issue. A lot of missed opportunities. I did the first brown bag that I did was on a lot of missed opportunities and failures that we had. Anybody else? But, some of these other guys will talk. Ricky, you want to?
Yes, have our invited responders come up and respond.
Really, with Ricky, he works at Project Champs. They're navigators. They also have their CACs, which is Certified Application Coordinators for ACA enrollment, and that was part of the reason I wanted him to come, just kind of speak on their situation and what they see as they're doing this.
As Dalton said, my name is Ricky Vaughn, and I work for Project Champs here in Lubbock. We fall under the umbrella of the South Plains Community Action Association. We're the local Rhine-wide provider for the Lubbock area. We get state and federal funding to provide medical and social services for people with HIV. As Dalton also said earlier, I've been kind of around for a while. I started volunteering in '95 in HIV services when there wasn't a lot of medication options. I think there were 2 at the time. We still had healing houses where people went to die because they got their diagnosis 6 months to a year later, they were dead. And that was the span of time that we had them in services. And so as you move forward to now where we're at in this completely different era with HIV, and even just in the last year, the medications and the things that have come out as far as HIV treatment have just catapulted us so far forward to where we're treating a long-term chronic infection now, as opposed to kind of poking a stick at this crazy virus that we found. It's really kind of put a different spin on care, I guess, from our perspective, because you went from a time where we'd had people for 6 months to a year, and now we're looking at having people for their lifetime. And so the quality of care is kind of the piece that we're going into now, as opposed to the quantity, because before we were just doing this, and this as quick as we could to try to help them have this very short but good life, as opposed to now we have people who, you know, can go through and do all the things that they've ever wanted to do in life, have a normal lifespan, and they just may need some supportive services to help them along the way. Which poses a big problem based on some of the things that Dalton was talking about, because as you saw, and kind of as you didn't see too, over the course of the last few years, what you'll see is the number of infections in Lubbock has risen like crazily. I remember I used to work at the health department back in like 2006, 2007. We would have like 11 cases here or there, and now we're seeing over 30 cases a year. We continue to get new cases. Unfortunately, as Dalton pointed out in his presentation as well, Lubbock still gets a disproportionate amount of people who have AIDS as their first diagnosis, so which means we go to the hospital and they already have PCP pneumonia, they may have toxoplasmosis, they may have all of these other just very strange other things going on that are very, very expensive to treat. And so we're having to deal with a lot of those issues and try to help them get back to health, which is way more complicated than early treatment and just keeping them healthy. So for years and years and years, these grant funds that we have just been level. And so as this level of funding keeps coming in, our number of clients is far superseding this level of funding. Well, so then you throw in the sequestration, which automatically cuts this level of funding by 8%, and so now we're doing more people and more people and more people with less and less funding, because again, before we were losing clients that we had because they were passing away, but we're not doing that anymore. So we're maintaining these clients and getting new clients at the same time, all the time, and so that puts a lot of difficulty on us. So as Dalton also pointed out earlier, I wear 2 very, very conflicting hats at this point in time. And so today I'm talking to you from the lead medical case manager point of view. But we also are doing navigation for the Affordable Care Act, which means we're charged with educating the public and enrolling people into the marketplace and helping people get referred where they need to be. Well, from that hat, it's a little bit different talk that you would be hearing. But from the lead medical case manager's perspective, Ron-Watt providers long have dealt with people who don't have insurance, because you can't get coverage for somebody who has HIV. It's a pre-existing condition. It's nearly impossible to make it the year of coverage before you could actually get their insurance to start kicking in, if they could be covered at all for private policies. There's all these rules and stipulations. Well, awesome, we have this new Affordable Care Act coming in. Pre-existing condition falls away. I mean, that's amazing for people with HIV because they can get health coverage now. But what it also doesn't take into effect is that for all of that time that we were treating people without insurance, we had so many good deals and contracts and different things going on with all these different providers that we could treat somebody with HIV for literally $500 a year. $500, and that is labs, doctor, medication, everything. So then you throw in all of these people who have insurance now, and these people, and this is starting to build up as well. And so what we're having is we're going from paying $500 for somebody's HIV care to $7,000 to $12,000 a year for insurance premiums, co-pays, deductibles, and all of those things. Because the thing is it's still very expensive to have HIV even with insurance. Co-pays have catapulted. One of the ways, yes, all of the plans have to have antiretroviral therapy, but a lot of them are moving HIV medications to tier 3 medications where now you don't have a $50 copay, you have to pay 33% of the medication. Well, for those of you who don't know, HIV medication is about $3,500 a month. So 33% of that is still more than I could afford on my salary. And so you take somebody who maybe is at about 150% of poverty, there's no way. So those are kind of the things that we're seeing. I kind of just wanted to, epidemiology is great, but, and I respect it, I'm a public health guy, but it's also really important to put a person's face on those numbers, and that's kind of where we're coming from. A lot of people have a lot of preconceived ideas of what people with HIV are or look like or what got them there. But I work with a 3-year-old who was diagnosed with HIV after birth because the doctor didn't follow up with what he needed to do to prevent her from being HIV positive. I work with a 50-year-old woman who was married for 20 years and found out that she needed to get tested because her husband's death certificate said that he died of complications of AIDS. So I work with a lot of people, and yes, we do have those people that are out there that are sleeping around, that are doing the things that you shouldn't do. But I think a lot of times if you're really, really honest with yourself and you really, really think about it, there are very few people in this world who haven't put themselves at risk for having HIV. And the only difference between them and us is that we were lucky. So that's about all I have. Thank y'all.
Well, we're
Do you want to say anything? Okay. Well, I have 2 announcements to make. If you want a copy of the PowerPoint slides that Dalton had, if you'll just put a star by your name out there when you signed in, we'll make sure that you get a copy. It'll be emailed to you. It might take a couple of days. It could be sometime next week. And then also, I want to invite everyone to the 6th annual alumni event. It's 2 weeks from today, and it's the 5th and 6th, or 5 to 6?
5 to 6.
From 5 to 6 in the Cardwell Welcome Center. The event celebrates what it means to be a nursing alumni at LCU. So, thank y'all very much. Any other comments? All right.
Let me just make sure Dr. Losey's still Dr. Losey? Hey, we're about out of time. Anything you want to say really quickly, or? Okay, thank you.
Just repeat it,
He said, I think I did a good job on touching on epidemiology and showing the other side of things and whatnot. So,
What about Dr. Bonner?
he said we're out of time.
All right, well, thank you all for